Hi, my name is Alicia Jade Hickey and this is my Airway video. Today is the 26th of September 2013. Standard precaution gloves and goggles. I'm going to go through 6 skills. They're going to involve the triple airway manoeuvre, the lateral position, OPA, NPA, laryngoscope and the BVM ventilation. First of all, I'm going to do the triple airway manoeuvre. Depending on the size of your patient, if you have an adult, you'll put a 2 to 5 centimetre pad underneath their head. If they're a large child, just leave them supine, and if it's a small child, a 2 centimetre towel underneath their shoulders. This is to help straighten their airway. This involves 3 steps: the head tilt, the chin lift and the jaw thrust. First of all, the head tilt, I'm going to place my right hand with my thumb facing down the nose and my left hand within the pistol grip with my index finger and thumb on the chin, and in one motion I'm going to tilt the head back and lift the chin up. From here I'm going to go into the jaw thrust, put both hands on the side of the head, 5th, 4th and 3rd finger along the mandible, my index finger on the body and my thumb across the cheekbone, and in one motion again tilt and then protract the chin forward. A common error for this skill is that when doing the chin lift, people can occlude the airway with their other fingers. I will now do an OPA insertion. This is indicated for an unconscious patient who needs airway support or a patient with bite block. It's contraindicated for any patient with a gag reflex or any patient with trismus. First of all, you need to measure the OPA. You do this by going from the corner of the mouth to the edge of the jaw, and this one will be suitable size. This is important to ensure adequate airway support as well as to prevent mucosal injury. You will lubricate it with water or saliva. And now for insertion, we'll hold it by the flange and insert it with the curve facing up toward the head. And as we bring the tip in, we will then turn it 180 degrees and continue to insert. If it was a paediatric, we wouldn't turn it, we would just insert it this way, and if we need assistance to bring the tongue forward, we'll use the laryngoscope. So we'll continue to insert it like that to the edge of the lips. Make sure that you're not pinching the lips on the edge of the teeth. And a common error for this OPA insertion is that it's incorrectly measured and they can cause mucosal trauma. I'm now going to demonstrate the NPA insertion. This is indicated for any patient who's unconscious with trismus. It's contraindicated for any patient with a nasal trauma, a middle third facial fractures, or have had a neurological event or a TBI. We also show precautions for patients with cerebral spinal fluid coming out of their ears or nose, as well as basal skull fractures. So first of all, we need to measure the NPA. We'll go from the edge of the nose to the earlobe. If it's slightly too long, it's okay, you can just leave it out. You also need to look at the diameter of the NPA and make sure it's not too large for the nostril. Next, we'll lubricate it with KY jelly, which I won't do for now. So first of all, we need to look at which nostril is largest and then choose which one. Bring the tip of the nose up and insert the NPA at a 90-degree angle to the face along the floor of the nose. When doing this, we make sure we do not force it. It's meant to go in easily. So rotate it clockwise and anti-clockwise until it slowly goes in. It's important that it's not too long because otherwise it will go into the esophagus, and then slowly just insert. So that'll assist with breathing and also bring the tongue forward. I'll now use the laryngoscope to check a patient's airway. So first of all, we need to check the laryngoscope is working, the light is on and the bulb is secure. I'll hold it in my left hand with my thumb along the handle. I'll normally have suction on my right hand side for convenience. So first of all, we're going to have the patient in supine position with a pillow underneath, and I'm going to provide head support and tilt back. And I'm going to slowly insert the blade on the far right hand side to do an upper airway inspection. I'm going to pull the blade across to the right, checking whether there's anything in the upper airway. Now once I've checked that that's all clear, I'll then, on the far left hand side, slowly insert the blade slightly more to the vocal cords and then gently exert pressure to lift. And then I'm able to see whether there's anything down the follicular groove or any other obstructions. It is important here to do that gentle lift so that you don't cause any problems or chipping of the teeth on the patient, and then I will just slowly bring that out. I'm now going to demonstrate the use of a bag valve mask to ventilate a patient. First of all, we need to check that the mask is the right size for the patient. We also need to check that the cushioning is adequately inflated. So I'm going to position myself at the head with the triple airway manoeuvre done. I'm going to place the mask on the patient's face whilst placing my 5th, 4th and 3rd fingers along the mandible, my index finger and thumb free for the C grip to get an adequate seal. So the patient's roughly 80 kilograms, we're going to get 10 ml of oxygen per kilo, so roughly half the bag. I'm going to ventilate the patient at a rate of 12 breaths per minute, so roughly 1 every 5 seconds. Whilst doing this, I'm also going to observe the rise and fall of the chest, as well as making sure that I do not hyperventilate the patient and place oxygen into their stomach. I demonstrate the lateral position. So when doing this, we position ourselves nearly next to the patient. We check the pockets for dangers, any syringes or anything like that. Now first of all, we place the far arm out straight like that and the close arm across their chest. From here, we then flex their leg at the knee, and in one motion with our hands on the shoulders and the hip, we turn them on their side. We then adjust the position so the leg's up secure in it, and we make sure that this arm is not in their face. We also ensure that their head is tilting down and back so that any sort of vomit or anything can come out and we're still not occluding the airway. If they do have a suspected spinal injury, if there's a trained third person there, we can use them to assist.